Welcome, and this chapter will on vessels and the circulatory system will conclude our chapters that make up the cardiovascular system, hematology, cardiology, and now the vessels. Within this chapter, there's a lot of information that is somewhat redundant that we've already touched on, and there will be very specific things that will be required for you all as far as testing for the lecture quiz, obviously anything that I talk about, but those also for the test. The rest of this, there's a lot that is just FYI for your information that you won't be tested on, but that is included in the ebook chapter and these PowerPoints. So if I skip them and don't mention them in this lecture, it was not something that you would be tested on or be held accountable for. So even more reason, though I know that most of you all are very clued in to these lecture quizzes, and you know that when we talk about something in the lecture, you really need to know it, but even more reason to pay attention because there is a lot of information. So this can help to guide your study if you're paying attention to the notes that you will be writing down from this particular chapter. We will take a look at the general anatomy of blood vessels. We'll talk about blood pressure, normal pressures, and what is considered hypertension, high blood pressure, and hypotension, low blood pressure. We'll look at the capillary level because capillaries are actually where diffusion of solutes are occurring, both passive and active transport, but also is where osmosis is occurring, where water moves from one area of concentration to another. We'll take a look at the venous return and also define shock, and this is the basic things that we will take care of during this session. So we have already discussed the heart, but when we think about the heart as being a pump, we understand it's two pumps, the pulmonary pump and then also the left side, which is the systemic pump. In this particular chapter, it is mostly focusing on the systemic left pump of the heart and discussing that oxygenated blood will be sent to the arteries, the aorta, the ascending to the descending, and then breaking off from there to deliver oxygenated blood to our tissues and nutrients to our tissues, picking up waste products, and then coming back to the right side of the heart. So for venous return to the right side of the heart by way of the inferior vena cava and or the superior vena cava. What you can see from this little common route, though, is that not all arteries are exactly alike. There are large arteries like the aorta where blood will break off into the medium-sized arteries to small arteries, and then eventually to arterioles, large arterioles, medium-sized arterioles, and to small arterioles, until they are actually at a microscopic vascular level called capillaries. Our tissues are being fed with oxygen from the blood and with nutrients and even with fluids at a capillary level. So all tissues are infused with these capillaries. This is where that is actually occurring. As the blood moves through after it's given off oxygen and picked up CO2, it's still in this closed vascular system, and it is moving into small venules, moderate-sized, medium-sized venules to large venules, until eventually small veins, medium-sized veins, and then the large veins, the inferior and or superior vena cava. So that's that closed system that we talked about and how blood is transported through. Let's take a little bit of a look at the actual vessels of an artery versus a vein. When we look at arteries, we know that arteries are pretty close to the heart. So they're having to withstand a lot of pressure because they're close to the pump. So as the pump presses blood out, these vessels that are nearby are having to withstand quite a bit of pressure. And that pressure is pushing blood all along through the system. So when we think about that, maybe it makes sense to you that arteries, the middle muscle layer wall in an artery, is much thicker than in a vein, because by the time blood has moved to these microscopic single cell layer vessels called capillaries, the pressure has really dropped. The pressure can't be too high in these capillary beds, or it would rupture the capillaries, it would break the capillaries. So it's low enough that it's still moving, but not breaking the vessels. So by the time it gets to these venules and veins, eventually veins, the middle muscle layer wall is much thinner. The pressure inside the lumen where the blood is going to be much lower. But it's still, this muscle wall, this middle muscle layer is important because it is smooth muscle and it is contracting and dilating, and that is helping also the blood move along. So this is just some of the differences in the basic anatomy structure of an artery and a vein. So another term, and we saw this term when we looked at the heart, is anastomosis. And we said that term basically means that it is an alternate blood route, an alternate route, if you will, for the blood to be flowing. This, again, we understand that the pulmonary artery carries deoxygenated blood to the lungs so that the blood can pick up oxygen to deliver CO2 into the alveoli, and then be returned to the left side. So that's just some basic anatomy for that. And you can see the differences again in the small vessels as well. The capillaries, this is a great look at a capillary. This is essentially one cell layer thick sitting on a basement membrane. The reason it needs to be that way, the reason that we want it to be that way, is for rapid diffusion of solutes, gases, and other solutes, and then also a movement of water that is going to be bathing our cells, and so that is actually happening as well and entering into our cells. When we look at an illustration of a capillary bed, this is a capillary bed that's bathing the tissues the cells that would be near here. We understand that there are sphincters, which are round little muscles that open and close, allowing the capillaries to be filled with blood, nourishing those tissues, and or diverted away. Sometimes those sphincters are closed. It depends on the autonomic nervous system deciding where you need blood. I can give you an example of this just as an application. If you have eaten a meal a couple of hours ago or whatever, that meal is being churned in your stomach, and eventually it leaves the stomach to the small intestines, where you need to have the digestion completed and then the absorption of nutrients. So it means the GI tract is needing a lot of attention and blood supply. So these would be opened, and this would be helping with that. And the parasympathetic nervous system is when we know that we're digesting meals, we're absorbing nutrients, we're rebuilding tissues and whatnot, the housekeeping system. And then if you're in a fight or flight response, though, if the sympathetic nervous system is engaged, you need a lot of blood going to the large muscle groups, the gluteus maximus and the gastrocnemius, and the muscles that are going to help us to run, and or the muscles that will help us to fight. And so blood is going to be diverted to those muscles, and areas like for digestion and whatever, this is going to close off, and so the blood is going to be diverted to the areas that you need it. So not something you have to think about. Your autonomic nervous system is actually taking care of it. But that's just a little bit of the anatomy of capillary beds, but all tissues need blood, that pretty much a pretty constant blood supply, so they don't stay closed too long. These capillaries, again, are single cell layer thick. These little fenestrations fenestration, just another name to say that there are pores associated. So you can see the little pores here. So again, for rapid diffusion both passive and active transport, and then also for fluids. You can see they're so small that red blood cells go through capillary beds single file. This is a scanning electron micrograph of an actual endothelial cell, so you can actually see, it looks like these little pores are pressed, almost looks like a pressed filter, doesn't it? Okay. Just FYI, a lot of these slides will be FYI. I'm not going to ask you any specifics about this, but just looking at someone who is at rest, which would be very different than if they were active, but this is looking at someone who is at rest, where blood is actually located. We know that depending on an adult's size, there's 4 to 6 liters of blood circulating around at any given time, and this is just looking at someone at rest at what they are. Blood pressure can be measured. So blood pressure can be measured, and when we think about what the American Heart Association deems as a normal blood pressure for an adult at rest, we know that it's going to be this, the top number is the systolic number, and you know systolic means contraction, and the bottom number is the diastolic number, and that is going to be at relaxation. You might be asking what's contracted and what's relaxing. What this top number represents, the systolic number, represents the highest amount of pressure being exerted on those arterial walls at any given time, the highest amount that's ever being exerted. This is when the left ventricle contracts, is at its most forceful contraction, the systolic, the left ventricle. Then, in between, there is going to be this relaxation from that left ventricle relaxation where the blood, it's at its least amount of pressure. That's the diastolic number, the bottom number. So the American Heart Association for an adult would like to see someone at around 120 systolic and under 80 as a diastolic at rest. Now, for hypertension, which is high blood pressure is deemed to be a level of 140 over 90, and you all know what those numbers mean now. So 140 over 90 is considered hypertensive or high blood pressure. Hypertension is called a silent killer. The reason it's called the silent killer is that we have seen unfortunately, many people who have had strokes and or heart attacks that come in that never had any, when talking to family or talking to acquaintances, they didn't have any signs and symptoms. They did not know that they were hypertensive or at risk for cardiovascular incidents. Except that sometimes when you're talking to the family, they will tell you that, oh yeah, you know, they've been for the last year or so complaining of headaches or nosebleeds or, you know, whatever. But typically there are no signs and symptoms. So oftentimes this is why people go in and they get surprised when they get told that they have hypertension, because they haven't really had any complaints. And it's also why it's so vital to have routine medical screenings, which include blood pressure. Personally, when we were in the labs together, and I still have a CDIC course, but y'all aren't getting to do this, but we practice blood pressures on one another, and it's always, every session, there's a section where someone finds out that they're hypertensive, and they had no idea that they were. Now, when they do that in the lab, I of course send them, say, you know, recommend that they go and get seen by someone. But it really is almost every session that someone does find out they're hypertensive, they do follow up and, you know, then end up having to go on some sort of treatment plan. So depending on what is causing, you know, what their hypertension is. There are different types of things that can cause hypertension. There's something called primary hypertension, and then there's secondary hypertension. Primary hypertension means that is your disease. You know, you don't have high blood pressure because of something else. This is actually your disease. And we know that it can be familial. so it can be inherited. It can be because of sometimes lifestyles, so obesity contributes to that, but again, that would be another sort of comorbidity there. But sometimes there's just no reason, and so for primary hypertension, which is the diagnosis and maybe the only diagnosis, most of them are idiopathic. The word idiopathic, it's one word. Idiopathic means the cause is unknown. So it's really unknown why, but that is their disease, and then it needs to be managed. That's primary hypertension. Secondary hypertension is because you have high blood pressure because of another disorder, like diabetes mellitus, which we know puts an incredible burden on the vascular system, the kidneys, and the vessels, which can lead to hypertension. So now you're being treated for the diabetes, but you're also having to be treated for hypertension. So there are other, like I said, that's hypertension due to something secondary. Doesn't lessen, doesn't lessen the disease. It still needs to be addressed and needs to be treated. All right, hypotension means low blood pressure. And some people keep a lower blood pressure. I've known quite a few patients, and myself included, that for a long time, my normal blood pressure was 90/60. That was a normal blood pressure, and that is for some people. But you don't really want to see it go much lower than that. If it's dangerously low, if it's dropped that it's to a point that it's dangerously low, this is considered to be medical shock. That is the definition of shock, is dangerously low blood pressure. And as low blood pressure actually occurs, then blood is not being able to be moved through the system the way that it should, and there will be complications from that as well. So it's important that you know normal for resting adults, and you know really what's considered to be hypertensive and hypotensive. There is this gray zone between 120 and 140 systolic, and between 80 and 90 as a diastolic, that is called pre-hypertension. Many are now considering that to be essentially hypertension, but that is a window, that window of where patients need to be very concerned, maybe need to be addressing things like diet, exercise, things that they can do, and possibly even treatment that might end up being shorter term to get that corrected. Okay, so again, blood pressure changes with distance. So when you're close to the pump, obviously that's going to be really a lot of pressure exerted on that. If you've ever irrigated, like fields or whatnot, the pipes that are close to the ponds that you're irrigating from are really thick layered pipes. But the further you get away from the pump, the pipes are getting smaller, and they don't need to be as thick because the pressure's dropping once you're getting further away. It's the same thing in your vessels. They're doing the same thing. So when we look at this, we know that this is kind of a normal range. We would like to see the left ventricle just spit out, just contracted at its highest amount of pressure. Then it's at its most relaxed, most relaxed, and so you can measure this. Now, as you're moving away and you've gotten down to capillaries, I said the pressure can't be too high because you saw capillaries are so thin. This is where the diffusion has to happen in osmosis. So it's pretty low, but it's getting lower and lower. So this is what I need you to realize, that the right return to the heart, the pulmonary return, so the right return has to happen, and it's pretty low, the pressure. So, and remember, it has to be balanced because these two pumps must be working in synchrony, and there needs to be a balance, or blood will back up in one area or the other. So one of the ways that you get good right pump return, pulmonary return to the right side of the heart through the veins, is moving. Is simply moving, even breathing, changing the shape of your thorax and abdomen. Walking is going to be contracting skeletal muscles, which are essentially massaging these vessels so that blood can keep going back toward the right side. Veins have something that is unique that arteries don't. And what I want you to know is that veins have valves for this very reason, that the pressure is really low in veins. So between heartbeats, because this is a heart beating, between heartbeats, as the blood would want to drop backwards and go the wrong way, the valve will close in a vein. So that between heartbeats, the blood is going to be still going in one direction. Remember, valves' functions are to ensure one-way flow. If you've ever seen someone with varicose veins, what that is a faulty valve in a vein. So as instead of the valve closing, it prolapses and blood can start pooling in those veins, and it can stretch the veins out. We don't really want stretched out veins. We want veins to be kind of tight because we saw the muscle middle layer in the veins. And we said that we know that this muscle, when it contracts, is also ensuring the one-way flow. The valves close to ensure one-way flow. We're moving to ensure one-way flow to help with that. And that's helping the health of the right pump. That's what's helping the health of the right pump, which keeps it all healthy, right? So just moving. So some differences between veins and arteries is that veins have valves, and it makes perfect sense because the pressure inside of veins is so low that between heartbeats, the blood would want to, especially with gravity, would want to fall back, and we don't want that happening. The valves ensure that. Again, I've defined for you hypertension, and I've talked to you about hypotension. Now, some causes of hypotension can actually be if you're bleeding out. So if you're hemorrhaging, that would definitely decrease the blood volume, right? Dehydrated, because we know most of blood is actually plasma, and most of plasma is water. We can have too few red blood cells, which are the predominant cells. You learned that in hematology. So these are some of the causes of what would be considered clinical hypotension, not just that normal for that patient, but clinical hypotension. Hypertension, the problem is that it weakens these small arteries, and it can actually lead to what are called aneurysms. An aneurysm, I wish I could draw here. I guess I could if I had a whiteboard. Do y'all want me to draw a whiteboard? Get a whiteboard? Maybe. Oh, look, there it is. So when we think about an aneurysm, oh, y'all don't want to learn about that. But when we think about an aneurysm, if you think, well, that's not what I wanted. An aneurysm, you think about the, really, I don't want a graph. Why is that doing that? Okay, thought I was going to get to right. I'm not sure why it's showing a graph at this point. You know what I could do? What I could do is just erase. Okay, so maybe it'll let me write. It's not letting me write. You all didn't really buy into this, did you? All right, so maybe it will if I do this. It's not letting me write. Okay, never mind. Let's think about a vessel, a blood vessel. So when we think about a blood vessel and blood is moving through the vessel, we saw that it had several layers. The lumen is lined with endothelial tissue. The middle layer is muscle. The outer layer also epithelial tissue. But what happens with high blood pressure is that you can get a separation of those layers, and so blood will be forced into like a little blister. It will make almost like a little blister on the vessel. So with every heartbeat and push, the blood is pooling in that little blister and then going on its way, and pooling and going on its way, forcing through. So you can imagine that over time it is possible for that blister to get larger and larger and larger until it can rupture. So they don't all do that, but they can do that. So if the aneurysms are close to the heart, to the pump, like in the descending aorta, which is very close to the pump and has a lot of pressure associated with it, then they really watch, if they know about these aneurysms, they really watch and they measure that area that's bubbled out, like almost like a blister. And once it gets to a certain size, it becomes more likely that it's going to be a life-threatening event if it ruptures, and they can actually surgically repair it. But those are for the ones that they know. Most aneurysms that rupture, no one knew about them until they ruptured. And if it's a cerebral aneurysm, you can imagine the damage it can do depending on where it happens in the brain. It can be an immediate death. So again, it depends on where the aneurysms are. It depends on what kind of break there's been in the aneurysm. If it's been a slow sort of leaking, or if it's been, pretty much bursting and whatever. But they can be definitely life-threatening, and they can be life-ending. And it can be sudden sometimes. So that's what an aneurysm is actually all about. Now, it is important that our vessels have elasticity, and elasticity isn't so much about stretch, it's about return to the normal shape and structure. So that recoil, and that recoil is maintaining the blood flowing. So this is what we know, we really do need to have. As we age, the arteries are less distensible. So this ends up bringing up, like a natural aging process, is that blood pressure will start to rise a little bit. And so we understand that. Now, again, as far as resistance and how blood flows, we talked about viscosity. I told you that a lot of this would actually be repeat from some of the couple of other chapters in cardiovascular. The thickness of blood is dependent on red blood cell amounts and albumin, which is the major protein supplied by the liver and the plasma. So we understand that decreased viscosity, when you have anemia, when you've lost red blood cells for whatever reason, or you have hypoproteinemia, which you don't have enough protein in the bloodstream, we know that can happen. Increased viscosity can happen when there's polycythemia and or dehydration. Both of these put a burden on the heart. So this is something that we understand. The control of this is going to be local, neural, and hormonal. I told you it's part of the autonomic nervous system. You don't have to think about smooth muscle contracting or dilating in your vessels. Your autonomic nervous system is doing that, usually from a hormonal release of hormones that are actually making this happen. So we understand that actually happens. Let's see if there's anything else I wanted you to know from these. There will be a lot of things that I sort of skipped through. We had talked about baroreceptors and chemoreceptors when we were looking at the other chapters, but these are also referred to as reflexes now, so we know that this is what's keeping us in homeostasis as far as blood pressure goes. And I will kind of move through here because this was kind of repeat. So you can see on the carotid arteries that are delivering blood up to the head, neck and head region, and you can see where these are actually located. So just FYI there. What else do I want you to know? We understand that there are a lot of things that can influence this. If you're under stress, if you have anger, or being aroused, these can all increase blood pressure, as it should. But that's actually a normal, expected kind of response when you have that. We also know about these hormones. Angiotensin is the most powerful vasoconstrictor in the body, and we know that the kidneys secrete renin, the lungs and the liver both secrete precursor hormones to get to angiotensin, which is going to raise blood pressure. We have already talked about aldosterone. Please review this. Make sure that you understand. This is going to pull sodium in, and that water is going to follow sodium. It's going to cause you to lose potassium into the urine, into the filtrate that will eventually become urine. But anyway, we have gone over every one of these hormones look at them again. You will be tested on these again in this particular section. So review them. And make sure that you keep reviewing the hormones. So anyway, again, at rest, when looking at what is going on as far as, just where blood is and what's happening here, you can actually see some of these. This is all FYI. Now, again, I've talked about diffusion and osmosis. You've got little pictures you can actually see, and we will move on. I have defined for you edema as being an excess of fluid in the tissue spaces, which can be compromising in how those tissues are actually functioning. So when we think about this, we do know that there can be some causes like increased capillary permeability. There's several things that can actually cause that. We learned that histamines actually can cause that, right? But what this is going to cause is poor venous return. So congestive heart failure could potentially lead to pulmonary edema, and now the respiratory system's compromised, which is putting even an additional burden on the cardiovascular system. Kidney failure, so now there's going to be water retention, which we know plasma is mostly water, so that leads to hypertension. And again, histamines making capillaries much more permeable, water leaking through, but also the capillaries dilating, causing dilation of vessels. So hypoproteinemia, so again, this is going to lead to osmolarity changes. And we know that some of the things that can cause these types of situations are cirrhosis, malnutrition, burns, and kidney disease. Also, you can have obstructive lymphatic return. We'll look at the lymphatic system as a whole and how lymph actually functions. But I told you at a capillary level, there's osmosis, not just the movement of solids, but movement of water that's bathing our tissue spaces. But the water that was already there has to go somewhere. And that water is referred to as lymph. And lymph will be pushed into the lymphatic vessels and eventually, through the lymphatic system, return back to the bloodstream. But if the lymphatic vessels are blocked, then water will build in those tissue spaces. It has nowhere to go. When at the blood capillary level, when water from the blood plasma is moving into the tissue spaces, the water wouldn't have anywhere to go. And the lymphatic system can become obstructed. And if that happens, you will see edema in those sites as well. Now, some consequences leading to circulatory shock is when we think about this, there's an excess of fluid in the tissue spaces and low blood pressure. And what can happen is the oxygen delivery and waste removal can't happen the way that they should. So with decreased oxygen, cells aren't able to make ATP. They cannot function the way they can, and they can, as you know, without oxygen, it only takes minutes, right? And some of the cells most at risk for functioning as a nervous system, which is controlling all homeostasis, so it can actually lead to tissue necrosis, which is pathological death, early death to the tissues. Pulmonary edema can lead to suffocation. You can't move air. If your lungs can't change shape and size, air can't move, is not moving. Cerebral edema, so headaches, nausea, seizures, and eventually can even lead to coma. So coma and death. So we said that in the veins, the pressure has gotten so low that it's going to need some help getting back the right venous return. So we know that gravity drains blood, that can help if it's above the heart. But the skeletal system, moving our limbs, moving our legs, walking is so good for your cardiovascular health, just walking and moving, as I'm sitting here at my desk. But really, that's very helpful. Breathing changes the thoracic shape and size, so that is actually sort of pumping the blood through the veins, and that is continuing causing it to continue. Also, the heart's still beating, so the left ventricle is still pushing, so blood is still being pushed through the system. It's just that it's gotten pretty low. So this shows you some examples of how when, like skeletal muscle, and you're just thinking about the muscles contracting, it's actually squeezing the veins. You can also see the valve. There's a valve here, a little illustrated, ensuring the one-way flow. Is exercise good? Absolutely. So absolutely what we just said. And we don't want pooling. If pooling ever happens because of lack of prolonged just not sitting, then this can actually be a problem too. So circulatory shock. When we think of shock, there's some different types of shock, and you should know the terminology. The most common shock is hypovolemic shock, and that would just simply mean low volume in the bloodstream. So it means your blood volume has decreased for whatever reason. Now, the whatever reasons can be that you're bleeding out. So you're bleeding out somewhere. So that can be because of trauma. It can be because of burns or dehydration. You can also have obstruction. So obstructions because of tumors and or aneurysms. But this is the most common type of shock. You can have venous pooling because you stood for a long period of time without really moving. So gravity hasn't helped you in that situation. Typically what happens is that eventually you might pass out. And when you pass out, you fall over, and then that's actually going to be corrective, because that will end up helping when you actually do that. You just hope you didn't hurt anything when you fell. Septic shock is due to microorganisms. So infectious diseases, there are many microbes that produce toxins that can cause vasodilation and increase capillary permeability. And so again, with those, it's a double whammy. The vessels open up, that decreases the pressure, and they become leakier. Water moves out, and that decreases the blood volume, which decreases the pressure. So it's a double whammy with septic shock, and it can be, minutes can make a difference when someone has septic shock. And probably you've heard the term sepsis, which is an actively growing microorganism in the bloodstream, or sometimes called septicemia, right? Anaphylactic shock is due to an antigen that is causing an allergic reaction, and that allergic reaction is causing a systemic spread of these histamines. And again, histamines kind of get a bad name. They do serve a very important normal function for us on a daily basis, but if there's too many histamines flooding the system, capillaries dilate, they become more permeable to fluids leaking out, and this widespread, it's one thing if it's just in your nose, but if it's widespread happening, it affects the total volume of your bloodstream, and blood pressure can drop suddenly. So that's a life-threatening event. Some of the things that can cause that: bee sting, shellfish, peanut butter, allergies to peanut butter or the fungi associated with it. So those are some of the things that you know about. Compensated shock means that your body is going to react to this and actually get you back in homeostasis. So for example, the person fainting and falling horizontal, that's going to help them. These are the kind of things that can help them. Hormone secretions, that's all going to help. But if that doesn't happen, decompensated shock is going to be the next step that can happen, and without medical intervention, this can lead to death. So what's going to happen is that this can actually lead to the heart ending up getting a signal to just stop. All right, so I'm going to talk about this equation when we get to the respiratory system. So we will talk more about this when we get to the respiratory system. But again, we need our blood flowing. We need it to flow at just the right pace. We need for it not to be a burden on the pump. So we need the viscosity and osmolarity to be just right, so that water is also moving through the system in the way that it should. We want all of those things to happen, because it doesn't take too long for there to be serious sometimes permanent damage, and sometimes loss of life. So this is important, understanding how blood is moving through the system and what is actually contributing to that. A couple of terms that I definitely want you to know, they would be TIA, knowing exactly what it stands for, transient ischemic attack, and CVA, cerebral vascular accident, and this, the term here is stroke. TIAs used to be called early warnings or mini strokes, they used to be called. They're actually considered now by the medical community as a stroke. The difference in these is really the extreme, situation of how they're happening, and where they're happening. So TIAs are typically you're going to get signs and symptoms of these, but they resolve. So it's not enough. It's not enough that it's going to be causing typically permanent damage. They resolve, but they are serious. CVAs they are stroke, so the brain is infarcting from ischemia. So this is actually sometimes immediately fatal, but sometimes people survive this, but usually they're going to have permanent loss of some sort of facility. So they're either going to have like paralysis, blindness, not be able to speak, and or maybe communicate. So, and those symptoms won't go away. They'll keep those if they survive the initial stroke that actually occurred. It all depends. Recovery is going to depend on the surrounding neurons and how much damage was actually done and how quickly intervention actually occurred. The main thing about strokes, and I know you've had this, you see all the public health announcements and stuff on this, fast reactions are vital in helping people to survive, but also to lessen the possibility of permanent extensive damage. So fast action, and actually fast is a little phase, making sure people can smile, speak to you, talk, those things, and then seeking help as soon as possible. Now, the rest of these, like the circulation stuff, I'm going to skip by these because I will be talking about this in the respiratory system. But what I want to bring your attention to, and this is really important to see, is this slide, and I guess this slide is 55. Yep, 55. The major systemic arteries. They left out, I have no idea why on the slide they've left out the carotids, but these are the carotids, the internal and external carotid. Here is the left side and here the right, so carotid arteries. But the rest of them, because you all have learned bones and you've learned muscles and you've learned regions of the body, brachial meaning arm, popliteal or popliteal, this is meaning the back of the knee. So these, pedal meaning foot. It's not as difficult as you may think, but you would want to be able to label the major systemic arteries, including the carotids. Then if we move down, you would also want to be able to label, and again, I'm skipping some of this because we just don't have time in our courses to do this, the major systemic veins, which again, they left out the jugulars here. The carotid arteries bring oxygenated blood to the neck and head region, and the jugular veins are draining that region. So jugulars, make sure you add that here, the left and the right. But that would be another slide you would want to pay attention to, 67. And again, the rest of these are just sort of FYI. You will have a lab assignment where you would want to know the major systemic veins and the major systemic arteries. Pressure points, these are also maybe something to think about and look at. So these are some arterial pressure points where you can actually do pulses. So we talked about beats per minute, what we expect in a resting adult. And these can be measured. You would want to make sure that if there was compromised blood flow and maybe a lower appendage, that you would check these and be able to feel these and palpate that. You want to be careful how you palpate arteries, because you don't want to impede blood flow, but definitely these are measurable and you would be able to feel these. I think that we have finished this chapter. When you read through this chapter, you are going to see that there's some redundancy, but that's never bad, to review the hormones and or to review certain terminology. But there were some new things as well. So that ends our discussion on the cardiovascular system. So after you have done the assignments with this, you can, with hematology, with the heart, with the vessels, then you would be, and look at some of the disorders tables, you would be more than ready to take the multiple choice test on this system. And I am wishing you the best. Stay well.